Okay. Well, I would like to welcome everyone to the Epilepsy Foundation Eastern Pennsylvania School Nurse Webinar, Seizure Training and Action Plan. I want to thank you all for joining our webinar. I'm Sue Livingston, the Education Coordinator from the EFEPA. If you have any questions when we finish or need any more information, please feel free to contact me. Please note that to obtain Act 48, Act 58, or CE credits, the post-test must be completed at the end of this hour. I want to thank our panelists, Beth Bond, the Director Division of School Health, Pennsylvania Department of Health, and Dennis DeLugos for participating in this webinar. Dr. DeLugos is an Associate Professor in Neurology of Pediatrics and Director of the Pediatric Regional Epilepsy Program of the Children's Hospital of Philadelphia, Pennsylvania. He received his MD from Columbia University College of Physicians and Surgeons in New York, a residency in pediatrics at Thomas Jefferson University in Philadelphia, and Alfred I. DuPont Institute in Wilmington, Delaware, as well as a residency in neurology and child neurology at the University of Pennsylvania Medical Center and CHOP. Questions can be written on the chat line. Beth and Dr. DeLugos will answer as many questions as time permits at the end of the webinar. Let's begin. Dr. DeLugos?
Well, thank you, Sue, and thanks to Sue and Allison for organizing this, and thanks also to Beth for joining the panel. As you can see from the title slide, we're going to talk about seizure first aid, action plans, and delegation issues. And the main goal here is to be prepared to respond to a seizure emergency if one were to happen, but to not raise the already high levels of stress and anxiety that these patients and families undergo. So that's our goal, to really be prepared if needed, but to not make an already difficult situation worse if the medical circumstances don't merit that. So you can see our learning objectives here. We're going to talk about appropriate first aid for a student during and after a seizure, and then we're going to talk about when a seizure is an emergency, and also when it's not an emergency, and how to respond appropriately. And then we'll talk about seizure action plans, which are extremely valuable in helping families and schools, I think, work through a given patient's seizures. And we'll talk about delegation, in particular delegation of medication administration, which is an area that varies state by state, and we'll try to talk about some of the general issues involved there. All right, so you can see the slide on the screen now. Talks about routine first aid. And the first bullet point is probably the most important. Most seizures are not medical emergencies. Seizures are quite frightening. They can look quite dangerous, but they almost never are. You can be physically injured during a seizure, but if you avoid physical injury, and that's a big part of seizure safety, it is very rare to actually be harmed by an individual seizure. So when we talk about seizure first aid, it varies depending on whether the patient is aware or not, and whether their awareness is just different or altered, or whether it's lost. So you can see by this slide the fact that it talks about no change in awareness or altered awareness or loss of consciousness, that seizures come in many, many shapes and sizes. And as we go through the remaining slides, we'll get to talk about some of the different seizure types, because it's very important to customize the plan and the reaction to a patient's individual seizure type. But something that cuts across all seizure types is the last bullet point on this slide, which is don't give anything by mouth until the student is back to normal and able to swallow normally. And that includes the old don't put anything in someone's mouth if they are having a seizure. Whether it be certainly not your finger or anything, just don't put anything in their mouth until they're back to normal. So that cuts across all seizure types. Next slide. All right, so there are different types of interventions for seizure first aid. One type of intervention, which can be used at any time during a seizure, is activation of a vagus nerve stimulator magnet, or a VNS magnet. We call it swiping the magnet. And for those of you that may not be familiar with vagus nerve stimulation, we can talk about that in the question and answer session, but it's basically an implantable device, a little implantable battery under the chest wall that can have a seizure reduction effect in between seizures, but can also be activated to maybe stop or shorten a seizure. Other types of seizure first aid, are typically medications, are prescribed to be given at a certain point during the seizure. For example, after 5 minutes of seizure activity, or after 2 minutes, or after 3 minutes. And if those type of medicines are prescribed in that way, it's important to try to follow the time directions of the prescription. The temptation may be to give the rescue med immediately because the seizure, you just want to make it stop. But the reality is most seizures will stop on their own within 2 minutes. So the rescue meds are not always needed. And if they're given too soon, it just adds to the sedation following the seizure. So you do want to follow the time constraints and the time directions of most seizure rescue medicine. Okay, this slide talks about the first type of seizure. It's not necessarily the most common type of seizure, but it's a good starting point to kind of talk about the variety of seizure presentations. So this seizure is called a simple partial seizure, and what that means is that the patient remains fully aware during the seizure. One type of simple partial seizure would be repetitive shaking of one side of the body. Let's say the right side of the body is shaking in a rhythmic fashion. If you try to stop the shaking, you can't suppress it because the brain is causing the limb to shake, and you can't stop it with by holding let's say the arm down. And that can be one type of a simple partial seizure. So you are having a seizure, but you remain fully aware. And you can see the 5 things suggested for simple partial seizures. First and foremost, stay calm. You always want to time it. And one helpful clue or helpful hint for timing a seizure is once the seizure is identified, say the time out loud. So if a student in front of you right now were to start having a seizure, you might say out loud, seizure started. It's 3:43 Eastern Time. And that will help you remember what time the seizure started. It'll also help any witnesses or other people there remember what time the seizure starts. Because without that kind of precise start time, it's very hard to judge how long a seizure lasts. They seem like they last forever, but they don't. The vast majority stop within 2 minutes. So time the seizure in some way. Reassure the student that it's okay, that they're safe, and simple partial seizures are not dangerous. And then explain what's going on to others, and as always, protect the student's privacy. Now, one important part about a simple partial seizure is, and this is up to the physician caring for the patient, is it has to be identified as such. Because there's a lot of things that could cause people to twitch or shake that are not seizures. And they might be fully aware, and they might have a tremor, or they might have other kind of shaking. So not every shaking is a seizure. But if the student comes with a seizure action plan that has a simple partial seizure as one of their seizure types, then these are the steps to follow. Next. All right, so the next type of seizure is very common, complex partial seizures. So these are seizures that start in some part of the brain and then spread to enough of the brain that awareness is impaired, consciousness is altered in some way. And these can look 1,000 different ways. And it'll be very important that the seizure action plan describes what the complex partial seizure actually looks like. And so these are the recommended steps to follow during a complex partial seizure. Stay calm, speak softly to the patient, guide them away from harmful objects. Very, very important. Beyond staying calm, probably the most important thing is to help the patient stay safe. So get them away from anything dangerous. Probably a good idea to have them sit down. If wandering is part of their seizure, and sometimes it is, and they're resisting sitting down, then you'd want to try to allow them to wander, but in a contained area, basically so you can watch them and not let them leave. So most complex partial seizures stop within 2 minutes. Those that go beyond that typically stop within 5 minutes. But if a complex partial seizure lasts 5 minutes beyond what is typical for the student, then that's a flag that it's turning into a seizure emergency. Or if they have a complex partial seizure that, let's say, lasts 2 or 3 minutes, stops, they're not fully back to normal, and then another seizure happens, we call that a seizure cluster, that would also be an indication of a potential seizure emergency. So notice the fourth bullet point on the slide. It's very important. If the complex partial seizure lasts 5 minutes beyond what is routine for the student. So let's say the seizure action plan says that a typical complex partial seizure lasts 5 minutes. That's what they do. That is their typical seizure. So in that case, a 5-minute complex partial seizure is not a seizure emergency. It is the typical seizure of the patient. And in general, you don't want to declare that a seizure emergency until it lasts for an additional 5 minutes beyond what is routine. So if the typical seizure lasts, say, 3 minutes, then we would advise letting the seizure go for 5 additional minutes, say 8 minutes, keeping them safe, watching for other signs of danger, but let it go for 5 additional minutes beyond the routine before you activate an emergency protocol. Now, it's very important to stop and take a breath at this point, and I'll remind everybody that these are not convulsions. Complex partial seizures are not convulsions. These are not grand mal seizures. So this 5 minutes beyond what routine, 5 minutes beyond what is considered routine guideline implies the seizure is not a convulsion. We'll get to that in a second, and there'll be different rules for that. So you want to leave a lot of leeway with complex partial seizures before activating emergency protocols. Because they're common, they're very varied from individual to individual, and the patient and the family, they may have a tried and true way of handling a complex partial seizure. And that should be outlined in the seizure action plan. So to turn a seizure that is not an emergency into an emergency we'd rather that not happen. Now I know we're asking a lot of you because everyone's a little anxious when a seizure's in progress. But if it's not a convulsion, if it's their routine seizure, we'd ask you to kind of let it run its course and see if it can stop on its own. Some things you should always do, even with complex partial seizures, are don't try to restrain or grab the person. That will probably just make them more agitated. And don't shout at them. Don't expect them to understand you. They're not fully aware. They may not be very aware at all. So they're not going to follow instructions. So just gets back to the importance of safety, just physical safety. All right, next, the next seizure type. And the rules are going to be very different for this type of seizure. A generalized tonic-clonic seizure, also called a grand mal seizure, although we prefer the term generalized tonic-clonic. So this is your full-blown convulsion. Often it begins with a cry, the body stiffens, and then shakes rhythmically, and usually all arms and legs shake. Now know that any partial seizure can turn into a generalized tonic-clonic seizure. So if you go back to that complex partial seizure we talked about, let's say it starts as a stop, stare, maybe they're drooling a little bit, they're not responding, and then shaking begins and it turns into a generalized tonic-clonic seizure, then that's different. Then you want to follow the guidelines on this slide. So with generalized tonic-clonic seizures, again, protect them from harm, observe the time, say it out loud, make sure their airway is not obstructed. You don't want to put your finger in your mouth, but if you can visualize it or turn them on their side to make sure their airway is clear. You want to cushion and protect their head. Best that they are on the ground. If they're not already on the ground, the best position during a generalized tonic-clonic seizure is on the ground. That's the safest place. So you want to cushion their head, turn them to the side, and remain with them until they're fully conscious. And you definitely want to follow the seizure action plan, because these generalized tonic-clonic seizures may be more likely to become seizure emergencies if they don't stop within a few minutes. And again, most stop within 2 minutes. Vast majority stop within 5 minutes. But want to be obviously extra cautious about any generalized tonic-clonic seizure. And like it said on the previous slide, it doesn't help to yell at them or to try to restrain them, because they're not in control of their functioning at this point. All right, so when is a seizure an emergency? Now that we've talked about 3 different types of seizures, when is a seizure an emergency? Well, a first-time seizure is always an emergency, not because the seizure is necessarily dangerous, but because you want to find out why. It's a medical emergency to figure out why someone had a first-time seizure. First-time seizures typically are short as well, but if it's the first time, then that requires a medical evaluation. A convulsion lasting more than 5 minutes. So a grand mal seizure or a generalized tonic-clonic seizure that doesn't stop within 5 minutes is considered an emergency, because the vast majority of them do stop within 5 minutes. Repeated seizures without regaining consciousness, whether it's a complex partial seizure or a generalized tonic-clonic, even if they're short, if they happen back to back to back like a cluster, that's an emergency. More seizures than usual, or a change in seizure type. Well, to judge that, you have to be familiar with the patient's baseline seizures, which is a big part of the seizure action plan. If a student has diabetes, why is that an emergency? Well, because it may be a sign that their blood sugar is really low. Any seizure during pregnancy is an emergency because it can be harmful to the fetus. A seizure in water is an emergency, especially if there's any shaking involved. A simple partial seizure in water, when they're fully aware and know what's going on, is not necessarily an emergency. but other seizures that occur in water are at higher risk for an emergency. Obviously, anytime a student is injured, that's an emergency, or if the parents request an emergency evaluation. And we'll get to that when we get to the seizure action plan. But the key thing is what's in italics at the bottom. You want to follow the seizure emergency definitions as defined by the patient's individual seizure action plan. Because for one patient, a 2-minute convulsion might be an emergency. For other patients, it might be 5 minutes or everything in between. So rescue meds. Rescue meds have been a terrific advance in the treatment of seizures because they allow us to shorten seizures but to not give unnecessary medication on days when patients aren't having seizures. They're prescribed both for seizure clusters, individual seizures that occur back-to-back, and also for prolonged seizures, which, let's just say 5 minutes is a typical length for a prolonged seizure. And the emergency protocol will include the name of the medicine, how and when it should be given, and that's usually like give rectally after 5 minutes or something like that. Specific instructions about dosing and timing, and then what to do following administration, which is usually just keep them safe and watch, and then how to monitor for side effects and things like that. And the most, far and away, the most common side effect for seizure rescue medicines is going to be sedation. There's really not much more dangerous that's going to happen from medicines given rectally than sedation. And then, as always, you want to follow the seizure action plan. So a couple of unique situations. What do you do if someone has a tonic-clonic seizure or a generalized convulsion in a wheelchair? Well, these are some helpful hints. Don't remove them from the wheelchair unless that's necessary. Secure it so the chair doesn't move. Make sure the seatbelt is fastened, but it's fastened loosely. And you want to remove any harness belt to keep them from choking. As always, protect and support the head. Watch the airway. Allow secretions to flow out of the mouth. Pad the wheelchair if it's not already padded to protect them from injury. And then follow the general first aid protocol, which we'll come to in a second. Seizures on a school bus. Obviously a cause of great anxiety for families and school officials, and it's something that needs some thought up front. First thing, and this may be obvious, is the bus driver should pull over. If there isn't an attendant on the bus, then it will honestly fall to the bus driver to go back and make sure the student is safe. So they pulled over, the bus is in a safe location, the other students are okay. The bus driver should go back and make sure the student's safe. And this is one way to think of being safe on a school bus. The student is lying on one side across the seat, facing away from the seat back so their face is forward. And if that doesn't work, then put them in the aisle, anywhere that's flat and safe. Then you want to follow the standard seizure first aid protocol, which will be outlined on the seizure action plan until the child regains consciousness, and then either continue to the destination or follow whatever the school policy is for a seizure on a school bus. I think this is our last special scenario, seizures in water, especially convulsions or tonic-clonic seizures in water. Most important thing is to keep the student's head above water. You do want to remove them from water as soon as possible, but even before that, get their head above water. And then they're safe, because they're not going to aspirate. If they're not breathing, then you need to begin rescue breathing and other CPR if needed. And it's probably a good idea, if at any point their head was underwater, to have them evaluated in an emergency room or by a medical professional. Because the risk of aspiration. And an exception to this would be if it was a partial seizure and everyone is certain that their head never went underwater, then I don't know that you have to take them to the emergency room. But if any part of the seizure involved their head going underwater, then I would suggest an emergency room evaluation, even if they look fine. All right, so that's the end of the first part. Now we're going to go on to the seizure action plan section, which is in some way most important. So seizure action planning, 3 phases. You can remember it by ACT, A-C-T. You want to assess the student's needs and gather information, and that's up to the family and the healthcare provider taking care of the child's seizures. They will customize the seizure action plan and then pass it on to the school personnel, and you can tailor the interventions to the classroom situation and the bus situation, etc. All right, so this is the very helpful, very well-designed seizure action plan that was created by the Epilepsy Foundation. So we'll go through it section by section. So the left side, it has some demographic information, in name, etc. Then the seizure information, the seizure type or the seizure nickname. And the parents should really fill this out, because in the end, the doctor will sign it. But it's very important that this be in language that the parents and other caregivers can understand. So they may have a nickname for a seizure. That's there on purpose, because families have nicknames for various seizure types, and you might as well use that. And then describe what happens during the seizure, how long it lasts, and how often it happens. And many patients will have one seizure type. Others will have more than one. If there are any triggers, and usually there aren't, to be honest, but if there are triggers, it's helpful to list that. And then daily seizure medicine. So these aren't rescue medicines. These are daily medicines that are given whether there's a seizure or not. And then other seizure treatments, the main device used now is the vagus nerve stimulator. And then if they're on any special diet, there are a variety of diets for patients with seizures. Most of them involve extra fat, sometimes large amounts of extra fat, but that should be noted as well. And then any special instructions can be put at the bottom of the form. So think of the left side as that's useful information on any day of the week, because the patient has seizures. The right side is really the emergency part and the action plan part. And you'd only really get involved with the right side if a seizure happens at school. So it begins with seizure first aid, which is really true of every seizure, and we covered these already. Be calm, keep them safe, pay attention to the airway, time things, stay with them. So that's seizure first aid. This next section is probably the most important part of the right side of the page, because this is where a seizure emergency is described. So what is a seizure emergency? Because not every seizure listed on the left side of the page is going to be a seizure emergency. So this might be a seizure that, as it says there, is either long or a cluster, or just happens back-to-back too much, which is also another way of saying cluster. So the seizure emergencies are described. And then the next section, the as-needed or the rescue treatments are described. And the most common prescribed rescue treatment is going to be rectal diazepam. Most brand name is Diastat. And that will be, say, rectal diazepam, 10 milligrams, when to give. After convulsion lasting 5 minutes, how to give PR, per rectum. And there are other rescue medicines that can be used where you can give medicine in between a seizure cluster. So a seizure has stopped, and you give medicine in between to try to break the cluster. And then the next section is, when does this really become a seizure emergency such that you have to call 911 or seek emergency medical attention? And we've covered these already for the most part. Seizures that last longer than convulsions that last longer than 5 minutes. Seizures back-to-back without recovering. If the rescue meds don't work, if there's an injury, if there's ever any instability in their breathing or heart rate. Unexplained fever. That would mainly be a sign of, is there an infection involving the nervous system? And then the contacts at the bottom. And then parents sign it, physician or nurse practitioner signs it. And if this is filled out carefully, then everybody's on the same page, and this is an incredibly wonderful seizure action plan. Very well designed, and extra thanks for the EFA for putting that together. So questions you might ask parents of students who have seizures. Well, the seizure action plan is great, but you may have to encourage them, nudge them a little bit to fill it out and have their physician or healthcare provider sign it. I think it's helpful, independent of the seizure action plan, or certainly once you get it, to do your own interview with the parents and just hear for yourself verbally how they describe the different seizure types and what they think is a seizure emergency. And then you want to update it at least annually, or if any other changes occur. Another valuable form is a seizure observation record, and I'm just going to go to the next slide to show you what it is, and then we'll come back and talk about it. So there's the seizure observation record, which is basically a way to keep track. Consider it a seizure calendar, keep track of seizures. Now we'll come back to that in a second. So it helps identify seizure types, duration, triggers, and any other patterns. And the value of the observation record is it may help in determining whether the seizure action plan is adequate. Let's say that on the observation record you're getting just more seizures than you'd like, but the seizure action plan indicates that those seizures are not supposed to be very common. Well, something's changing. So that might be a chance to nudge the family to have a follow-up visit with their physician or nurse practitioner to find out what's what. So here's the actual seizure observation record. Now, there may be various seizures observed on here. That doesn't mean they're emergencies, but this form is detailed enough that it sort of gives more flavor to the various types of seizures. So the seizure action planning process, it requires a team effort with the student, the parent, the healthcare providers, obviously the school nurses and other school medical personnel. But the bottom line is it's supposed to provide information about the seizures, seizure emergencies, and then basic first aid, emergency first aid, and then any interventions or rescue medicines that are given. It's signed by both the parent and the healthcare provider and the school nurse, so we're all on the same page. You want to make sure everybody has it and update it annually, or if any other change happens. So just as part of, let's say you have all that information, as I said before, it's still a good idea to talk to the family directly so you get the history right from them. If there are any questions with the seizure action plan, then you can contact the student's medical team. You'll need permission from the parents to do so, but that can be very helpful to clarify misunderstandings, and then document any in-school seizures using that seizure observation record. So transportation issues require some extra attention. The bus is a high anxiety environment for families, and it will vary from patient to patient and school district to school district, whether there's an attendant on the bus or not, and what the bus drivers are trained to do and expected to do during, if a seizure were to happen on a bus. So obviously communication is very important. It may be good to, in the beginning, to communicate with the parents more frequently about how things are going, and then, as everyone gets more comfortable, to do that occasionally, but not necessarily daily or weekly. There's a lot more to having epilepsy than just having seizures. There's other things that can come with it, learning issues, behavioral issues, and all of those are part of, for many patients, what it means to have epilepsy. And obviously you can talk to the parents about concerns you have as well. If there's a substitute teacher, then you might want to make sure that they have access to the seizure action plan, because things have a way of happening when we'd rather them not. So make sure your substitute teachers are aware. All right, so I'm going to now turn things over to Beth, who's going to talk about some of the tricky delegation issues, and then we'll have a chance to take questions at the end. So Beth, I'll be your slide advance if you want to take us through the next few slides.
Okay, will do. The first thing to know is that one of the things that shows up on the slide several times is to look at the state laws and regulations in regards to delegation. And the Pennsylvania Nurse Practice Act is silent on delegation. Some folks have interpreted that then nurses may delegate. However, back in the 1990s, the Board of Nursing tried to put regulations through and include delegation language. There is something called the Independent Regulatory Review Commission that looks at all these regulations and compares them against the laws that they're providing the additional support or the additional assistance to. When the Independent Regulatory Review Commission looked at these nurse practice regulations against the Nurse Practice Act, they went back to the Board of Nursing and they said, you can't do this. There's nothing in the law that allows you to put delegation in your regulations. If you look at the Medical Practice Act, it has delegation in there, so the medical regulations have a whole chapter on delegation for physicians. But as nurses, we are not allowed to delegate in Pennsylvania. However, we have federal laws that are listed there, Section 504, ADA, and IDEA, which require schools to make accommodations for students, so that even without being allowed to delegate medication administration, which is a nursing function, schools still have to provide care for students and make accommodations. So next slide, please. And this slide and the following one, you can just go to the next one right away, talk about tips to effectively delegate, and that is acceptable in other states, but not in Pennsylvania. Now, when we talk about delegation and not being allowed to delegate, that is nursing function. So like medication administration is considered a nursing function. The VNS that was spoken about earlier, the vagal nerve stimulator, is not considered a nursing function. And so unlicensed persons may be trained to apply the VNS. They should only do that after they've been properly trained. We have been asked about nurses doing the training, and that's only if you have the expertise and knowledge to provide that training, should you be doing anything. And I'm guessing the majority of us that work in schools or have a school nurse background do not have the expertise and knowledge to provide that training, and we really need to turn to folks like the doctor and his staff to provide that training for any of us that will be working with the VNS. Okay, and we'll go to the next slide. And one more, where it says the challenge of delegation. So the challenge is we have the diazepam rectal gel. We now have the intranasal Versed and other medications that are being ordered for these students. So schools really need to take a look. When you get that emergency plan from the provider and from the parents, you need to take a look at how these medications can be handled safely in the school setting. Do you need to put a nurse on the bus with that student? Or are there nurses along the route of the bus that would be able to respond quickly enough? And there are some other ways, some other suggestions that the Division of School Health has worked with schools on making sure that we make the accommodations that we have to make, but don't have nurses violating the Nurse Practice Act and affecting their licensure. And we may have more questions in regards to that when we get to the question portion, or if you have questions that are not answered during our time span here, you can certainly contact the Division of School Health, and we'll help you work through those issues. Because the bottom line is safe care of kids, and as was spoken of earlier, not raising the anxiety level of families. Okay, on to the next one, and that's back to you.
All right, so thank you, Beth. So Sue and Allison, what would you like to do at this point? Do you want to go through a seizure action plan, or do you want to open it up to questions?
Well, I think one of the questions we got, Dr. DeLugos, was about a VNS, and I think before we go to the question, maybe if you could go into a little bit of detail about what the vagus nerve stimulator is, just so that everybody is sure about what we're talking about here.
Okay. All right. So the vagus nerve stimulator, or the VNS, is a implantable battery or an implantable generator that's implanted under the chest wall muscle on the left side. So under the pectoralis muscle on the left side, that's where the little battery is put in. And then a wire is connected from that generator to a nerve in the left side of the neck called the vagus nerve. And the vagus nerve is a nerve that leaves the brain stem, or the lower part of the brain, and goes all throughout the body. It goes to the neck, to the heart, to the gut. The vagus nerve goes lots of places. The generator delivers a tiny electrical stimulation to the vagus nerve that then travels northbound to the brain, and through some unexplained way, that electrical stimulation of the brain through the vagus nerve can have a seizure reduction effect. So think of it as like a seizure medicine. And the vagus nerve stimulator is programmed to go off at designated times. It might go off for 30 seconds every 5 minutes. And there's all kinds of ways you can customize the stimulation. But this daily autopilot electrical stimulation, it's just there in the background, and it's just happening. Nobody has to do anything. Now, we don't know why it works, but the other part of the vagus nerve stimulator is you can activate the generator by swiping a magnet across their chest muscle, and that is programmed to give an extra electrical charge, a little extra boost, just during the moment you activate it. And again, the slang term that's used is called swiping the magnet. And you think of that as the rescue treatment. And that has been reported to shorten seizures or stop seizures in some cases. Or it shortens the postictal state or something like that. So that's what the VNS is. So it is a medical device. It's not a medication. And the kids will typically have their little magnet with them. They often wrap it around their ankle or something, so it's there. If you do have a student with a VNS, then it's a good idea to either talk to the nurse or nurse practitioner at the neurology office about it. They can give you an in-service. Or the company that manufactures it can also come out and give you an in-service and provide education on what VNS is all about and how you'd activate the magnet. So that's the quick scoop on vagus nerve stimulation.
The question that we have about the VNS is if a student has a VNS and has a sudden cardiac event where the use of an AED is indicated, is the AED use contraindicated in any way?
No, that's fine. They're AED. To me, AED means anti-epileptic drug, but I'm thinking in this case it means automated external defibrillator. So we keep our AEDs straight. No, you can deliver an AED with a VNS in place.
Okay, can we move to the next slide?
The next slide?
Yes.
That one?
Oh, yeah. And I just want to let everyone know that they can visit the Epilepsy Foundation websites to find out more about our Project School Alert programs for the Epilepsy Foundation Eastern Pennsylvania and Western Central Pennsylvania. We do provide in-services for school personnel and programs for students. We also assist with IEPs and 504s. We do school nurse trainings in your district or nurse trainings for any agencies or organizations. Do we have other questions? Please don't forget to complete your post-test. You finish up? I think there's one more question.
Okay.
A real-world scenario. There's a first grade student with rectal diastat order and tonic-clonic seizures. Had a seizure 1 month ago, field trips in 2 weeks, and the parent is not available to attend the trip. I put a substitute nurse request to attend the trip and notified my nursing advisor of this need. Because I will be in a building of 700 students that day and can't attend the trip myself, if there is no sub available that day, I would feel it would be against the Nurse Practice Act to attempt to train a teacher how to administer diastat. Your suggestions? Beth, this goes to you.
Yeah, and bottom line is if there's no nurse to go on that field trip with a student who's had a seizure so recently, then the rules for those federal laws are that the field trip has to be canceled. The student may not be canceled out of the field trip. So it really behooves the school to try to find, and not necessarily you as the nurse, this is administration's responsibility, to find the substitute to go on that field trip. Some other options would be, are there any other parents going who are licensed medical professionals? If so, then I would get them as an approved volunteer for the school district, where they get their clearances, they have their TB test, and go through the school board as an approved volunteer, and then they would be available. Some schools have looked to rely on emergency medical services as a backup for not sending nurses, and that's not a good option, because if you call an ambulance and it's a basic EMT who arrives, they may not give diastat. So that's not going to help you any, and there's no guarantee from your area, wherever that is, that a paramedic is going to be available. So it really falls back on the school to provide the accommodations that they are required under federal law to provide. And if you don't hear back from your school administration or from your coordinator, that's something that we deal with all the time in talking with administrators, and would be willing to assist in educating them to their responsibility.
Okay, we have another question about delegation, and Beth, I don't know if you can answer this. The question is, I know we are talking about kids and school procedures, but how does protocol delegation differ when dealing with adults with disabilities and epilepsy and day programs?
The Department of Public Welfare has different regulations, and so it really depends on the type of program the person is in as to who is allowed to administer medications or not. So that would vary according to what the licensure is for the facility, and that would come out of under Department of Public Welfare.
Okay. See, I just want to check and make sure we've answered all the questions that we have.
And Sue, while you're looking, if I could just add that, as you said at the beginning, this session is being recorded. We are going to post this onto Learning Management System so that nurses who were not able to attend today can still go back and get this valuable information. Along with the training, we want to be able to provide some additional resources. And so if you have students that have dietary accommodations for their seizure disorder, there is a special form that needs to be filled out by the doctor, and that will be listed on there as a resource. And also for the transportation plan for buses, there's an individualized transportation plan that will be that's available from the Department of Health that we'll make available, as well as the seizure log and the seizure action plan.
And Dennis, can you move us along to the last slide, please? Thank you. And I just, as I said, wanted to remind you all that you can contact the Epilepsy Foundation websites, both the Eastern Pennsylvania and Western Central Pennsylvania. Don't forget to complete your post-test, and thank you both very much, or thank you all very much. Thank you, Beth, thank you, Dr. DeLugos, and thank you all for joining us.